let me invite Dr. Poonam Malhotra to talk about recent advances in ECMO.
Thank you, Dr. Khanna, for giving this opportunity. In fact, it's always a pleasure to be a part and parcel of the APVIC programs over the years. The APVIC programs have done wonderfully well, and it's really a proud privilege to be a part of this time, even though it is not physical, but to be here is enough to speak about the state of ECMO as it exists in the country today. We were very lucky in the last couple of years to be doing some ECMO in COVID with disastrous results. But what we learned is a lot more to improve our patients in the post-COVID era. So I bring you greetings from my alma mater, AIMS, where ECMO came in 2002. We had very bad results with a mortality of nearly 70% till 2010, when we started doing what was known as integrated ECMO. And integrated ECMO paved the way in a very big way. We are primarily a pediatric center where a lot of tertiary complex congenital cardiac surgery is done. And if you see the patients that come to us, whether it is a truncus or a arterial switch operation or a obstructed APVC intracardiac, the initiation of a CPB or an ECMO brings about hemodilution. It brings about a hypothermia with dilutional coagulopathy, contact factor pathway activation, and all of this leads to an inflammatory process with the generation of thrombin. Now, thrombin generation is something that is disastrous and worsens the inflammatory process. And at the center of all this is nothing but the platelet. Platelet is the universe which brings about all the contact factor, tissue factor pathway activation. And from it begins the factor 10, factor 10A activation, which is also very, very bad in an ECMO patient. But if you put this patient on an ECMO beforehand, and this is what we did from 2010 onwards at AIMS, we started to put our patients with the surgeon putting the cannulas preemptively as if you're coming off not on CPB after the surgery, all elective surgeries, but you're coming off after the CPB on the ECMO circuit. This ECMO circuit was similar. We were at that time in 2010 onto the roller ECMO pumps, but today we have the CPB pumps. Our 10-year experience is wonderful on integrated ECMO. The mortality of 70% is reduced to a mortality of 27% today. And the circuit after surgery is just the way we wanted the circuit to be on a veno-arterial ECMO for these pediatric neonates as well as infants. So integrated ECMO circuit, with the CPB incorporated, increase the preparedness and the availability. It cut down the assembly time. What were we doing before? The patient would come off on a low cardiac output and we would juggle for the ECMO machinery. But here we were prepared. We were coming off on the ECMO. It reduced the possibility of CPR resuscitation. It is very, very cost effective because you're not using duplication of cannulas. And the pump today is a good centrifugal pump. And we were extending the boundaries of creating a historic win over using the integrated ECMO circuit for a DTGA with an intact ventricular septum, even in bigger babies who were more than 3 years of age. So when we did this, the concept and design of the integrated ECMO became very, very paramount to our circuit. And along with it, from high flow ECMO, the recent advances towards a low flow ECMO. Why? Because the low flow ECMO, because of technical advancements in the ECMO machinery that we are seeing today, we use the CardioHelp. The clinical management available for short-term as well as long-term ECMO applications became much, much better. And today you have, from the roller pumps, those centrifugal pumps, or the cones as we call them, which cause less hemolysis, which cause less platelet dysfunction and thrombocytopenia. And we can evaluate the level of perfusion at low flows with less hemolysis than at high flows. So if we need central cannulation, which brings us better drainage, oxygenated blood, post-cardiotomy, especially in cardiogenic shock, the peripheral vascular disease also entails a central cannulation over a peripheral cannulation. But one of the most recent advances in the use of ECMO, particularly the veno-venous type of ECMO, is the percutaneous treatment of using the peripheral limbs for cannulating. Why? Because the availability of the peripheral cannulas became much, much better than what it was before. So if we use the semi-open technique or the open technique or the semi-cell linger technique, the risk of vascular complications became less with these very, very naive and very new enriched siliconized ECMO percutaneous cannulas for both veno-venous as well as veno-arterial, where the femoral vessels could be cannulated or the right internal jugular vein could be cannulated with a dual lumen cannula like the Avalon. And if the Avalon was causing a lot of thrombosis, today we have the Crescent cannula, which is even better than the Avalon. What came in was the pumpless ECMO, the use of end-tidal carbon dioxide removal in a very, very smooth way. And if you use ECCO2R with peripheral cannulation, you just need a small pump, which is put between the groin or the two legs of the patient, and contralateral two femoral vessels, whether veno-arterial or both the femoral veins in a veno-venous are connected, and there is removal of carbon dioxide, which brings about absolutely good results because CO2 retention with PCO2 being very high was causing a lot of acidosis and giving bad results on ECMO. So AV shunt kind of a picture was put in. A very major recent advancement has been the use of lung protective ventilation. The lung rest, which we use as ventilation therapies, better ventilators, APRV, inverse ratio ventilation, with the use of high frequency oxygenation ventilation, has brought about very good adequate gas exchange, keeping a PIP about 30 to 35, keeping the PEEP between 6 to 7 or less than 8, with a rate which is less than 35 and an FiO2 less than 50%, and a tidal volume in the ultra protective is as low as 3 ml per kg body weight. This brings about fantastic results, especially on the veno-arterial cardiac ECMO. Another very, very useful part was the use of echo during ECMO. And if you use echo, the patient selection, if there was a aneurysm of the aorta, or there was a PFO, or there was a small obstruction in the RA, because RA is the area where most of the cannulas are going to lie, then we would not use central ECMO in this patient. But as we talked about the acute decompensated heart failure, where we want something temporary to give us some results before we use it as a bridge to transplant or a bridge to bridge or a bridge to VAD or a bridge to recovery or destination therapy, where clinical judgment, echo variables, and hemodynamic parameters are not enough, we started to use better anticoagulation. And when we started to use better anticoagulation, moving from heparin, which was a culprit, from high dose to low dose, and during the pandemic, a heparin-free period. This is where we are today, giving bouts of 2 to 3 days of heparin-free period. Most of the COVID patients were on low molecular weight heparin, so we did not add heparin. And to our results and to our happiness, the ACT, the APTT, and all the anticoagulation parameters remained within normal limits. Today, what we need are not just heparin bonded circuits. We need a biofilm or a biosurface which has added nitric oxide, which gives a good intact endothelium kind of a result. Probably that's where the research is, and that's where we're going to be going. But something that if can be added along with an echo to an ECMO machine is the use of a point of care analyzer. A sonoclot, a TEG, or a rotum, if you add it and implement protocolized algorithm-based rotum studies or TEG studies, where you use the R-TEG at parameter or as well as you use a APTT, then one test would tell you which blood component to give. It is very easy to monitor because the turnaround time is 5 to 10 minutes. And using low molecular weight heparin, the anti-10A, if that was the monitoring technique that we needed, the R-TEG gave as good a result for anti-10A, because getting anti-10A in even a city like Delhi became difficult during the COVID time. And what did we develop at AIIMS? We developed algorithms for these point of care tests, where we use platelet function tests on the rotum or on the sonoclot, where a PF SON on the sonoclot of less than 0.9 told us that there is thrombocytopenia and you don't need to give whole blood or cryo or FFP, but your patient needs just single donor platelets. So research was done by a lot of people in Germany, a lot of people in Europe, and point of care algorithms became a norm on ECMO patients. This is where we are today. We pick up these, we give the right component. It is never always whole blood. Why? Because we are in a restrictive transfusion phase, and that's what the patient blood management therapy and the guidelines from European Society also tell us. The advantages of ECMO in a acute decompensated heart failure patient cannot be overlooked. You need an IABP, but IABP alone is never enough. With big cannulas being put in, an IABP with ECMO can exist today, and a lot of guidelines coming up from all over the world in the West today is on how to judiciously use ECMO with the IABP. And using ECMO as an LVAD therapy, just bridging it before an LVAD, particularly before a lung transplant, you need a veno-venous ECMO. So ECMO as a bridge to transplant came up, ECMO as a bridge to VAD or destination therapy came up. And ECMO with IABP and ECMO with VAD together can be put for 3 to 4 days on a patient. And these are some of the most recent components of the use of ECMO.
Dr. Poonam, please conclude your
I'll just
slide.
wind up. So if we categorize the ECMO centers in the country from 8 to 9 have today picked up to more than 59 centers. We formed the SWAC ELSO, the Southwest Asian ELSO, with the ELSO of Dr. Robert Bartlett from Michigan. And we came up with anticoagulants and blood product usage in a very, very good way so that the 3-pillar component, multidisciplinary, multimodal therapy of patient blood management could be maintained. Anticoagulation is where we are. It's an enigma. Using the right anticoagulant is not just heparin, but doing away with heparin because it's the only agent which can be neutralized is also not one. So we need direct thrombin inhibitors and alternatives to heparin. Another thing, and this is my last recent advance, is the use of cytosorb, particularly in ECMO with sepsis. Cytosorb removes the cytokines, the plasma kallikrein pathway, and this takes away all the inflammatory markers and has shown that patients on whom a cytosorb was kept with ECMO, the ECMO removal and weaning off and trial off was much faster, as you can see in this slide, and the use of ECMO with cytosorb is on the rise. I would like to end by saying that whether it is COVID or whether it is any inflammatory marker, using expensive therapies may not be there, but cytosorb as a bridge is there. What we need is nitric oxide. Inhaled nitric oxide is also added on to the ECMO therapy, and advances in ECMO management may help complications compared with inception, but we need antithrombin 3 with heparin, which is the prodrug, as the cornerstone of anticoagulation to be done away with, and urgent need for more research in this field is what is warranted. Learning from each other, taking out academic portfolios and taking out books and journals on ECMO is need of the hour. And ECMO today stands tall in every ICU because of learned behavior post-pandemic. Thank you so much for giving me this opportunity.
Wonderful, and I would request you to be in the panel